Well, good evening and welcome to this CPD Me webinar. My name is Andrew Umrod and I'll be facilitating tonight's webinar, and I will very shortly be handing you over to Professor Matthew Reid, talking all things aortic dissection, quoted one not to miss. So I can see there is lots of people jobbing in online now, as you do. So good evening from Team CPD Me. I'm here. I've got some team in the other room doing all things social media and magic. And welcome to this wet and windy Tuesday night. Well, it's certainly wet and windy where we're broadcasting from. I'm not sure where you are, but we've got an absolute excellent webinar prepared for you this evening. So just all we need you to do is basically make yourself a brew or a cup of tea, or a glass of water, maybe a glass of wine, sit back and enjoy this amazing informal learning. In the chat, I can see already that we've got Helen who said hello. Cathal is good evening. Jessica, hello. Hi, Paul Seymour, who's a nurse. Evening, Paul. Always good to pop in the chat where you are dialing in from. Keith from a wet Leicester. Yes, Keith, it's miserably wet and cold up here too. So always good if you can pop in the chat, maybe what you do for a living, where you're dialing in. Danielle is a student, paramedic from Scotland. Good evening, Danielle. Phoebe, who's from London, I think. Well, that was moving very fast. I can't see it now. Claire from Portsmouth. Andy, who's a critical care paramedic from Montana, USA. Good evening to have you on board. I was over in EMS World recently with Dr. Linda Dykes and met lots of critical care paramedics. Sorry, Irish paramedic. It's all right. I'll excuse you, Cathal. I hope I'm pronouncing your name right, by the way. We've got Alex, who's a NQP, newly qualified paramedic from EMAS. Great to have you on board. I love it to pop in the chat where you come from. I probably could have been a social worker in my previous life rather than a paramedic, because I just like to be nosy, I think. So I like to see where people are dialing in from. No offense to social workers out there. I can say that because my other half's a social worker and equally as nosy as I am. So if you are new to webinars, then you can probably just close off from here. But if you are sat there in your satin embossed robe or your matching gym jams with your partner, wife, husband, or other half, or maybe half naked slumped on the settee, then don't worry, because we can't see you. Or maybe you're just sat there looking absolutely exhausted because you've just finished an absolute run of shifts and perhaps having a glass of wine. Don't worry, I'm not here to judge you, but we can't see you and we can't hear you. But if you have any questions for Professor Matthew, then please pop them into the questions and answer box, and then we'll answer them, or as many of them as we can, at the end. And of course, if you are a premium member of CPD Me, then you will get the certificate and the evidence and such that will drop into your portfolio, and I'll show you how that works in a second. And of course, you'll get access to the recording on your CPD dashboard. That will be all nicely polished tomorrow by Team Fabio, Team Amy, and Team Jessica. If you are going to get social with us, then do please tag us in on social media. It's always good. You've probably seen this week that we've give away, I think, about 100 cups. So please do tag us in with hashtag CPD Made Simple. Take us a selfie. Maybe you sat there with a big screen on. I realize that you can download our CPD Me app and then live stream it to a big TV, so it looks like almost like a CPD Netflix. I think I'm allowed to say that without a legal battle. But it allows you to do it and put it on a big screen, because I've seen a few this week. So as you always know, if we do tag you and like you on social media, then we will send you one of our CPD Me cups. And the good thing about these cups is when you scan the QR code on the front, it goes through to all of the amazing free up-and-coming webinars. So please do tag us in on social media. 7 good reasons to become a CPD Me member. If you're anything like me, I struggle to capture and record my CPD, and what we created back in 2009 was an absolutely amazing way for you to capture and record your CPD. Even more easier when, in fact, you use our mobile app, because just like tonight, once you've attended the webinar, the mobile app will receive a copy of the certificate, a copy of the log, the title, the date, and all the information around tonight's webinar. That just literally leaves you to go in and reflect around it. So all you need to do is, once you get notification on the app or your email, click into edit, and then all you need to do is reflect around your learning from tonight's experience, and it makes capturing and recording CPD simple. So it puts the evidence there, it puts your certificate there, then all you need to do ultimately is dictate into the app what have you done, why have you done it, and how might that influence or change your practice, but more importantly, how will that support the patients or the way that you do your job for the future. So it really does make recording CPD super simple. And of course, for the premium package, it's £17.99 per year. I honestly don't know how we do it, because that includes access to over 400 recorded webinars with automatic certificates, along with 80 live webinars per year for £17.99. Now, we often get lots of people saying, is this monthly? Definitely not. It's per year. And of course, for access to that, you get all the goodies that I showed you previously. Plus, if you go into absolute meltdown mode because you've been picked for the amazing audit, then you can ring one of the team up and they will literally walk you through the audit process and show you how you can get your portfolio prepared for submission. So there is a free version. You can download the app and try the free version, but I would strongly recommend the upgrade because you get lots of goodies. And even more so if you are a student, because we've just received funding for 100,000 students across the footprint of Scotland, England, Ireland, and Wales. So now is a good chance to get your camera out, take a picture of that screen and share that with anybody you know who is a student, because as long as they've got a student ac.uk or IE or any prefix, as long as it's a student email address, they will get free CPDME access for their duration of their studies. So please do share that with friends and colleagues. This week, we've had, I think, 185 new students join, so one definitely not to miss. Now, you probably all know that we don't spend any money on advertising here at CPDME. We spend the money from your memberships back on bringing you live presenters and amazing speakers like Professor Matthew tonight. So, but we do rely on some genuine reviews on Trustpilot, Google reviews and such. So please do leave us some genuine reviews because it's really, really important that that supports our business moving forward. Okay, are you sitting comfortable? Well, I know quite a few people are because I can still see there's a lot of people. Erica, ICU nurse from New Zealand. Evening, Erica. Gosh, I wish I was in New Zealand. I bet the weather's nicer there than it is here in miserable Manchester. And we've got also Lily, who is a final year medical student from Romania. Great to have you on board. Lisa, who's a medical editor and dissection survivor from Harrogate. Evening, great to have you on board, Lisa. Fabulous. So, are you there, Professor Matthew?
Hi, yes, I'm here. Thank you very much.
Stop sharing my screen. Let me click this magic button. There we go. The arena is all yours.
Right. So can you see that first slide?
I don't think it's loaded up just yet. 1 second. You might just need to click the share screen option again at the bottom.
Okay, let me do that again. Yeah. Okay.
Perfect.
Good. Great. So thank you so much for that introduction and for the opportunity to speak to you all this evening. Such a huge range of people from all over the world and from such different backgrounds. So delighted to be able to speak to you. There are my details there. That's my Twitter link. It looks like from the introduction I need to get a bit more up to date down with the kids and get my TikTok link as well. But that's my details. So yeah, so I'm Matt Reed, and a little bit of background about me. So this is where I work. I work in Edinburgh. It's a beautiful place, a bit cold, wet and windy tonight, as I'm sure all of you are as well. As you realise, not Scottish. I came up here about 20 years ago and haven't left since. It's a great place to visit if you haven't already. This is where I work, and this is important just for a little bit of background when I talk about some of the epidemiology of acute aortic dissection. We see about 120,000 patients a year in our emergency department in Edinburgh. We're a major trauma unit. We see hyperacute stroke. We do stroke thrombolysis and an intervention, and also see all the primaries for cardiac angioplasty. So we're a busy unit. There's one other emergency department on the outskirts of Edinburgh, but essentially there's just the two departments in the whole of Edinburgh. I do a large amount of clinical work, but also I'm lucky enough to have 2 days a week where I do academic research time, and this is our research group in Edinburgh. A big group. We are one of the leading recruiters to emergency medicine trials and have one of the largest portfolios of emergency medicine studies in the UK. So that's a little bit of background about me and where I work. Tonight, I was going to cover the following 5 topics. So first of all, I'm going to talk about epidemiology of acute aortic dissection. Who does it happen to? What are the demographics? Then we're going to go and talk about some pathophysiology. what is it about? What actually happens in this condition? And to clear up a couple of confusions around it as well. I'm going to talk about the symptoms. So really important, what do we need to look out for if we're considering someone might have an acute aortic dissection? And also, when should we consider it? And we don't consider it enough. And that leads me on to diagnosis and why we miss it. And I'm going to finish up with a little bit about how can we actually improve how we do here. And we're going to talk about some other strategies that are available to us to help us think about it and help us to diagnose it, and things that might improve in the future. So I'd like to start by telling a story. This is the case of Mr. S, who was a patient I saw in our emergency department about 6 years ago. And I was working in our rapid access assessment triage area, where we just sort of eyeball patients and try and get treatments or investigations ordered early, as many of emergency departments across the UK have. And I saw Mr. S, who presented with a cold white arm. It was his left arm, and it had been present for about 6 hours. No other presenting symptoms, and I did actually consider acute aortic dissection, but it looked very much like a fairly straightforward case of an acute embolic event causing an acute limb ischemia in his arm. He went through to our main bit of department, and I handed him over to the consultant in that part of the department who saw him and agreed that there wasn't anything else to consider or to suggest aortic dissection. We phoned the vascular team, and he went to theatre later that afternoon, where he had a brachial artery thrombus removed. Went back to the ward, and very tragically at 3 a.m. That evening, I had a cardiac arrest on the ward. Now, his post-mortem showed that he had a type A acute aortic dissection. And going back through the story, it turns out a few weeks before, he had presented to our acute medical team with some fairly, from the notes, benign sounding chest pain. He was worked up as an acute coronary syndrome and was discharged with a negative troponin. And whether this was the point at which his dissection occurred, we don't know. But clearly, that information may have made a difference. It may have not. So that's a bit of personal experience. Now, I'm certainly not alone, having misdiagnosed a case of aortic dissection. This is some data from the last 10 years in our 2 Edinburgh hospitals. And there are 26 patients that we have not initially made the diagnosis for acute aortic dissection. But it's not only us. So about 1 in 3 of patients are misdiagnosed who have aortic dissection. And a quarter of patients are not diagnosed until at least 24 hours after they presented to the emergency department. I'll touch a bit later about the negligence claims associated with it in a recent report this year. And the tragic thing is we know that the prognosis is best when patients are treated early. So for every hour of delay in making the diagnosis from when the dissections occurs, mortality increases by 2%. But if we do diagnose it and we treat it early, 80% of patients will survive if they've reached hospital. So a bit of background, there are 4,000 patients a year in the UK who have acute aortic dissection. Most commonly are the type 1s, and I'll talk about what a type 1 aortic dissection is. About half of these patients die before they reach hospital. So these would be patients who have cardiac arrest. Some of them may just die at home, and some may have cardiac arrest. But about 50% of them come into hospital. Now, I was always taught as a medical student that there were 2 clear peaks in the age incidence of acute aortic dissection, one earlier on and one much later. And the one much later in the older age group was larger than the earlier one. Now, this graph doesn't reflect this quite as much, but it does show the age groups associated with aortic dissection. But it still is really important to note that this condition that also affects young people. So 25% of patients were aged less than 50. Half of them are aged less than 60. So this is not only a condition that affects elderly people. It's unlike aortic aneurysms, which we'll talk about as well afterwards, which I have never seen in anyone less than 60. Aortic dissection can affect any age group, and that's because the older age group affected because of atherosclerosis, and the younger age group affected because of connective tissue disease that can cause dissection. So don't use age as a reason to not consider it. Now you might say, well, it's really rare. I'm just not going to see a case of aortic dissection, am I? And it may not be as common as some other conditions such as MI, but it is still not uncommon. 4,000 cases a year. I'm sure all of you who have worked in the emergency department will have diagnosed someone with a new diagnosis of a brain tumor on a CT scan with symptoms. About 50% of brain cancers are diagnosed in the emergency department. And it's as common as that. And this is the number of cases we've had altogether over the last few years in Lothian, which is our 2 emergency departments. So we see between about 15 and 20 cases a year. So most of our ED clinicians will see at least 1 case a year generally. So you will see a reasonable number of these over your career. Another statistic to put the condition into perspective, 2,500 patients die within a month of being diagnosed with acute aortic dissection. And that's very similar to the number that die or more from road traffic accidents and from PE. So it is a large cause of mortality. And that does put it into perspective when you think about the amount of infrastructure we have for managing trauma with major trauma centres and everything that goes on in the pre-hospital environment through to the systems we have in place in hospitals to manage patients coming with trauma, yet more people die of acute aortic dissection. And cases are going to rise. So because we're having generally an older age group, and it is more predominant in the sort of the 40 to 60, 70-year-olds, it does mean that cases will rise over the next 10 years. And we expect cases to rise up to about 6,000 in the next 10 years and ongoing. So it's not something that's going away. So that's a bit about epidemiology. Now I'm going to talk about some pathophysiology. So first of all, we're going to talk about the anatomy of the aorta. Now the aorta starts just at the aortic root, which the aortic valve obviously is the outflow tract to the left ventricle, which then has the aortic root, which is where your coronary arteries come off. And then you have the ascending thoracic aorta, which goes up to the arch here. And there are 3 main vessels that come off the arch. There's the right subclavian, the right common carotid, and the combined right subclavian and right common carotid, which is the brachiocephalic artery. There's the left common carotid and the left subclavian. And this is important when we talk about the type of dissection, whether it's a type A or a type B. And that is important because it influences the management that occurs. Now, the cutoff point is here, just after the left subclavian artery. And anything that affects the ascending, the root and the arch is classed as a type A aortic dissection. And anything that starts from after the left subclavian artery is a type B. If it involves both, it's a type A. So that's the anatomy. This is a cross-section of the aorta. So this is the root, this is the ascending arch coming up here, and this is your right brachiocephalic. And if we take a cross-sectional cut through the aorta, we see that there are 3 main layers. There's the intima, the media, which is a reasonably large layer compared to the others, made up of lots of connective tissue, and the outer adventitial layer. And this is really important when we go on to talk about what is the pathology that's happening here. And what happens essentially is that you get a small tear in the intima, so the inner lining of the aorta. And that small tear allows blood to go into this middle media area. And because the media is weaker than the other two walls, the blood, which is under pressure, because it's coming straight out of the heart under pressure, will then track up and down through the media, separating the layers of the intima and the adventitia, and it will just track all the way along. So that the blood will just track all the way along. So this is what happens. You get a little tear here, the blood goes in, and then it separates the inner and the outer layer of the aortic wall, and the blood tracks through this new lumen created within the aorta, which is referred to as the false lumen. Now, when we refer to acute aortic syndrome, we're talking about 4 different conditions. We're talking about acute aortic dissection, type A and type B. So that's 2 of the conditions that make up aortic syndrome. There's the intramural hematoma, which is due to bleeding within the media with no obvious tear in the intima. And this is thought to be due to lower pressure bleeding within the media. And there's also a penetrating atherosclerotic ulcer. So what happens here is that the blood tracks into the media, but because of atherosclerosis, it does limit the amount of tracking proximally and distally, so up and down the aorta. So you get a small area where you get ulceration, but you don't get tracking of the blood up and down because of this extensive atherosclerosis. But by far the commonest type is the type A aortic dissection. Now, this is a CT scan showing a cross-section of an aorta, and you can see this is called the dissection flap here, and there's the false lumen and the true lumen. Now, aortic dissection acutely is a dynamic process. So the caliber of the true and the false lumen is very dependent on the pressure in both of those lumens. And that will determine whether the flap moves more towards the true lumen or to the false lumen. So what happens when the dissecting process happens? The blood moves into the false lumen, and then a few things happen. Either the blood can rupture the aorta, so it goes out of the outer layer, the adventitia, rupturing out into the chest cavity, and that is normally a fatal condition. What might happen is the blood might track back into the proper aorta and create another tear where the blood goes back in and creates what we call a double lumen channel. So the blood can go either through both lumens, arriving back distally into the normal aorta. You might get a branch vessel occlusion, which I'll talk about. This can be complicated to understand what's going on here, but I've got a few diagrams to show you. But essentially, the false lumen has blood within it, and where branches come off the aorta, the true lumen, the false lumen surrounds them. And if you have high enough pressure in the false lumen, it collapses the true lumen and doesn't allow any perfusion of any of the vessels coming off the aorta. And as I'll go on to say, this explains why you can have bizarre symptoms like stroke. So it might occlude the left carotid artery, for example. You might find that there's a STEMI presentation, and that's because the branch to the left coronary artery is occluded. You might find that there's what looks like a left, or in the case of the patient I saw, a left arm ischemia, because the subclavian artery has been occluded. And it's dynamic. So as the pressure changes between the true and the false lumens, you can reperfuse parts of the body again. So you may have somebody present with stroke symptoms that then settle, and then they have an ST elevation on their ECG, which then changes, and then they might have stroke symptoms again. And that's why this can happen. Now, this pressure can stabilize over minutes, hours, at the most a few days. So that pattern can change, but does stabilize after a while, and you can get a chronic picture. Now, I said, if the blood ruptures out of the false lumen into the chest cavity, you either get a big mediastinal hematoma, a hemothorax, or big pericardial effusion, which will lead to tamponade and is fatal. And we think about 7% of out-hospital cardiac arrests are due to type A aortic dissection and are unsurvivable. Now, this is the branch vessel occlusion. So what happens here, as I was explaining, is the true lumen. You have a vessel coming off of it here, but the false lumen, if you imagine this is in cross-section, is surrounding the true lumen. And as the pressure goes up in the false lumen, it blocks off this vessel here. So you don't get perfusion to this organ. You can also have the case where the false lumen has so much pressure in it, it completely occludes the true lumen. So this is the false lumen here, and this is the true lumen. So you get very poor perfusion distally down to the lower limbs. I've mentioned classification. There are two classifications. The main one that's of any use is the Stanford one, where we divide it into type A and type B. Type A is proximal and type B is distal. And the reason we use this one is that it mandates what treatment's required. So a type A aortic dissection is a surgically managed management with cardiothoracic surgeons replacing the arch of the aorta. With type B, it's a medically managed where we lower the blood pressure to allow the dissection to become chronic and to settle down. And that's managed by medical teams, normally cardiology, in a CCU environment. Now, I wanted to touch on this to distinguish the difference between an aortic dissection and an aortic aneurysm. They're very different pathologies. They present in very different ways. The treatment's very different as well. And it is very easy to confuse the two. And commonly when you're working in the emergency department, you'll hear medical and nursing staff talking about doing bilateral blood pressures in both arms to see if there's a difference. And the reason we do that is because possibly if there is a dissection and you have, as I said, knocked off the true lumen to one arm but not to the other, you'll get a different blood pressure, or you might not get a pulse in one arm, but you may in the other. Now, this is specific to aortic dissection. Aortic aneurysm can affect the thoracic cavity, but more commonly the abdominal cavity, where we get an abdominal aortic aneurysm. And this is a slow ballooning of the aorta that happens over years. And slowly the aneurysm enlarges and enlarges. And when we get to about 5 or 6 centimeters, there's a risk of it rupturing. It ruptures and you either get free blood into the abdomen or tracking into the retroperitoneal space. So it's a complete rupture of the aorta. This is very different to a dissection, which is where you get this tear in the inner wall of the aorta, causing blood to track between the layers of the aorta. Patients who have an acute aortic dissection, although they may not have a normal aorta pathologically, may have a totally normal looking aorta to the eye, to the naked eye. Whereas with patients with an abdominal aneurysm, you'll see the moment before it ruptures will have a large ballooning of the aorta. Now, these are two different conditions. A abdominal aneurysm presents with a sudden onset of back or abdominal pain with collapse and the very hypotensive patient due to sudden onset of hemorrhagic shock. Aortic dissection presents in a different way, which we'll go into. So let's talk about the symptoms. So the symptoms can be due to 3 main different parts of the pathology. So first of all, the dissection of the aortic wall is extremely painful. So it's a sudden thing. It happens in seconds. The tear, the blood gets into the tear and into the wall, the middle wall of the aorta, and tracks up and down, peeling away the aorta, which is intensely painful. Now, this happens immediately. So the pain is sudden, it's intense. It might settle, and that's when the dissecting process stops, the pain may settle, but the actual event of the dissection is painful. We may have a contained rupture. So I've talked about what that might entail where the aorta itself ruptures. You may have a big hemothorax causing symptoms. And there's also the symptoms of malperfusion. So with the dissection itself, we've talked about there being intense pain. We've talked about the fact that it might improve. And some people say it's described as a ripping pain or tearing pain, but this isn't particularly accurate. If there's a contained rupture, the patient's severely unwell with blood in their chest, around the heart, with effusion or a pericardial effusion. And they tend to be very unwell with breathlessness and hypotension. Or they may present with symptoms of malperfusion, and this is where the dissection process has taken off some vessels coming off the aorta. Now, as I said, this may be transient because it does depend on the differential flow between the false and the true lumen, and it can change. And as I said, if you'll remember my initial diagram of the aorta coming out of the heart, just at the level of the aortic valve, the coronary arteries come off just after that. So if you get dissection goes all the way back to the aortic root, you can lose the right or the left coronary artery, giving you a STEMI mimic. We've talked about the carotids causing a CVA mimic. You may knock off your mesenteric arteries, causing ischemic colitis symptoms predominantly. You may have ischemic limbs, and you may have a number of these, none of them, or one specific thing. So we know what it is. We know the pathology. So why is it so difficult to make the diagnosis? Well, one of the reasons is the commonest symptom of aortic dissection is pain. And that is also one of the commonest symptoms of conditions that patients present to the emergency department with. Patients can present with back and abdominal pain, but again, these are common presentations. And there are 2 million presentations a year to EDs with chest, back, and abdominal pain. Now, with chest pain, atraumatic chest pain, only 1 in 1,000 patients who have atraumatic chest pain will have aortic dissection, an acute aortic syndrome, which is what I refer this group of conditions of aortic dissection, AAS, but only 1 in 1,000 will have that, and 999 patients, 979, will have other causes that are not aortic dissection. And this is important when we think about, well, how we're going to diagnose it, because clearly we can't CT scan everybody who has chest pain. So this is a chart of all the major presentations we had to our ED last year. As you can see, chest pain is the commonest cause for presentation to the majors part of our department. And the problem with aortic dissection, it's absolutely classic problem of a low signal, high noise ratio. So the weak signal of the aortic dissection is overwhelmed by the background noise of all the patients that we have presenting with complaints that could but do not represent acute aortic dissection. So out of all of the patients we have chest pain, back pain, abdominal pain, there's lots of them. There's such a small number that have aortic dissection, and not all of them come in saying, hey, I've got an aortic dissection. I've got the most severest pain. I look absolutely awful. I've got very low blood pressure. I've got pericardial tamponade, and I've got Marfan syndrome. That doesn't happen. So the signal is very weak against a huge backdrop of patients who potentially could have aortic dissection. And research hasn't got particularly far with the diagnosis of this so far. We're good at treating it. And the reason for that is it's a relatively rare disease, relatively when we're looking at emergency department conditions generally. One of the reasons, which I'll touch on, is why it's missed is because we don't always think about it. And if we don't think about it, how can we enroll someone into a study looking at it? Because we haven't thought about it. It has multiple presenting complaints. As I've said, it's not just chest pain. It can present in other ways. If we consent people to studies and trials, then the problem is lots of these patients are unwell, so you won't be able to recruit them. There's something called the Hawthorne effect, which means when you start looking at a condition, you say, right, today we're going to study aortic dissection. You'll find that everyone in the department that day has aortic dissection on their mind and thinks of it in every patient that they see. And that's the problem with telling people that you're going to do research on it. I'll touch on D-dimers and CT scans a bit later on, but it's not a test that we do in everybody. So it's not as if we can do some observational work looking at how many patients come in with these things and how these things can help us, because we tend to only do them on patients when we're trying to rule out a certain condition. Now, we teamed up with Frimley Health to add to our data that we'd started to collect for the missed cases we had over the last 10 years to try and better understand why we miss acute aortic dissection. So we looked at M&M records, complaints, post-mortem reports, and we looked also at everyone who'd had a CT in the hospital downstream from the ED who had an aortic dissection picked up that we tracked back to the emergency department that we realized that we'd missed coming through us. We found 43 cases over 10 years. They were most commonly type A, no surprise there. The presenting features, chest pain radiating to the back pain, no particular surprises there. We looked at what alternative diagnoses were made in these patients. And here we start to get a little bit into why we do miss aortic dissection. So a third of these patients were thought to have acute coronary syndrome and diagnosed with that. There were 12% that were thought to have PE. There were 5% who were thought to have stroke. And there's some other symptoms, other conditions there, renal colic, esophageal spasm, that are well-known mimics of aortic dissection. And why did we miss it? So in 3/4 of these patients, when we look back all of them through the notes, there wasn't really much evidence that we'd actually considered aortic dissection as a differential. Once you consider it, it's very difficult really to rule it out, but we just hadn't considered it. So there needs to be more awareness of the condition to be able to think of it in patients who potentially might have it. In about half of patients, we decided there was an alternative diagnosis and we're happy with that. And we thought, yeah, it is acute coronary syndrome. I'm going to go down that treatment line. Or that we excluded acute coronary syndrome with a normal troponin, and we're happy with that as well and let the patient away home. A couple of other reasons. One was that we had a normal chest x-ray and therefore ruled out aortic dissection, which we cannot do, and which I'll come on to talk about. And also that we considered it, but the patient didn't have any of those classic signs. So they didn't have pulse deficit in both arms, so one arm having a pulse, the other one not. They didn't have a different blood pressure in their left and their right arm. They didn't have the classic murmur of aortic regurgitation, where the blood has tracked around the aortic valve and has made it incompetent. So they didn't have that, so we thought, no, they don't have dissection. Surprisingly, those patients, all the patients we missed out, those 43, 14 died, which is higher than the 80% survival rate if you make the diagnosis, but maybe not as poor as we were expecting, given that all of these patients had a delayed diagnosis. So in summary, we decided we showed that there was definitely a lack of considering the diagnosis, which probably comes through a lack of awareness. Some cases were atypical, but not always. We're particularly noticeable about how many patients had written in their notes sudden onset severe chest pain, and then it wasn't considered. Mimicking other disease, acute coronary syndrome, PE being the two common ones, and reassurance because they didn't have any typical clinical signs. Now, there's been another piece of work that has looked at factors that have caused clinicians to miss aortic dissection. And Lovat last year, a couple of years ago now, showed that those factors were, again, a normal chest x-ray was used to rule it out, and you can't do that. The patient has symptoms of other conditions. So, example, this was suggestive of a PE or acute coronary syndrome. But the patient walked in. So we think of acute aortic dissection as it is a severe disease. We expect patients to be really unwell, and a lot of the time they are. But if they've had the dissection and it's settled, they don't have the pain from that, they may well walk in. So we can't exclude it in someone who's just walked in. Again, this is one of the reasons it's so difficult. And similarly to us, the absence of typical symptoms. And I've touched on some of these typical symptoms. Now, whilst tearing, ripping description of the pain is suggested by some patients, if the patient doesn't have it, you can't rule it out. Not all patients have a tearing or ripping pain. And we've talked about a differential blood pressure. Not having that doesn't exclude it. Not having a pulse deficit doesn't exclude it. Patients can be acutely hypertensive, but again, if you're not, it doesn't exclude it. And I'm just going to let you indulge me for a minute here and give you a bit of some numbers for this. So let us think about those four typical symptoms. Now, there's something called negative likelihood ratios. You don't need to know what it is, but essentially it gives you a value between 0 and 1 that if you put a percentage on the likelihood of someone having a condition, and then you do a test or you look for something or a feature, if you apply that to your patient, does that make any difference to the likelihood that they have the condition? So let's say I've got someone in front of me in the resus room. I think there's a 50% chance of them having an aortic dissection. If I don't have, for example, a differential in their blood pressures, when we look at research, we find that the likelihood ratio there is 0.5. It only reduces that chance of about 15%. If it's 1, it rules it out. If it's 0, it doesn't make any difference at all. So let's have a look at that for these typical symptoms. So if you don't have tearing or ripping pain, you don't have differential blood pressures, you don't have pulse deficit, or you're not acutely hypertensive, the negative likelihood ratio is almost 1, which means that if you thought they had a 50% chance of it before, they don't have any of those things. They've got about a 45% chance still of having aortic dissection. So looking for these features and ruling it out because the patient doesn't have them really doesn't make any difference to the likelihood of them having aortic dissection. What about an abnormal chest X-ray or a wide median sternum? Well, here it's pretty much no better than tossing a coin. 22% of patients with aortic dissection have a totally normal chest X-ray. So if we do find a totally normal chest X-ray, the negative likelihood ratio is only 0.5, which means you're only reducing the chance of them having an aortic dissection by 10%. So if I thought there was a 50% chance of it before, and they've got a totally normal chest X-ray, they've still got a 40% chance of having aortic dissection, which is still significant. So we can't rule out aortic dissection on the basis of a normal chest X-ray. So what is helpful? Well, abrupt onset pain, so sudden onset pain, has an excellent negative likelihood ratio. So it reduces the chances if a patient doesn't have abrupt onset pain. It halves the likelihood that this patient in front of you has aortic dissection. It still doesn't rule it out, but it makes it much less likely. So this is a symptom we need to look for. And if someone has abrupt onset pain, we clearly need to be investigating further. Worst ever pain, again, is really common. So this is the subarachnoid hemorrhage of headache. Sudden onset, severest pain with chest pain is aortic dissection until proven otherwise. Same as sudden onset of headache is subarachnoid hemorrhage until proven otherwise. I touched on negligence reports, and this was released last year looking at negligence claims in EDs. And I'm just going to read this out because it's very telling. It says the most common causes of death in these negligence claims were misdiagnosed infection, PE, acute coronary syndrome, and aortic disease, including dissection. And they say they identified poor awareness and recognition of the significance of the presenting symptoms, along with evidence of lost opportunities to use information from the ambulance and triage notes. And I think you could probably put that to missing most conditions. The important thing for me is the use of the ambulance and the triage notes. Paramedics will write really helpful, useful information in the notes that may be lost in handover, and you have to read the ambulance notes for every patient you see. The patient you're seeing sometimes at the moment, many hours after they actually were had their initial symptoms, and the patient sitting in front of you with no chest pain, looking absolutely fine, is very different from the patient that the paramedics saw in their house moments after they had their sudden onset of chest pain. So this is really important and something I think worth taking away. So I painted a fairly bleak picture there of how we do with managing and diagnosing acute aortic dissection. So how can we do better? Now, there's campaigns out there. The Aortic Dissection Charitable Trust does a huge amount of education and have got some great resources online. There's a campaign by another group called the Think Aorta campaign to try and encourage awareness. However, over the last 10 years, since certainly the Think Aorta campaign has been around, we've noticed no difference in improvement in mortality or by detecting aortic dissection. So awareness is extremely important, and it is important that we have campaigns like Think Aorta to try and remember to think about it, but it's not the only answer. We did a clinician survey of practice across the UK with 56 EDs responding, and we showed that only 12% of EDs have a formal pathway for working up patients with potentially acute aortic dissection, and most were not really using any particular guidelines. The Canadian clinical practice guidelines were used in a few departments, and the aortic dissection detection risk score was being used in about 20%. Now, the reason probably that so few guidelines are used is that there really isn't anything that is particularly good, straightforward, simple to use, that gives us a good method of ruling in or ruling out acute aortic dissection. Now, this is the problem. If we think someone might have an acute aortic dissection, the diagnosis or the investigation to make the diagnosis is a CT scan. Now, we can't CT scan everybody who has acute chest pain, because if we do that at the moment, the yield of picking up acute aortic dissection on CT is about 2%. And that might be fine because it's such a serious condition. But if we start getting into lower numbers than that, we're doing far too many CTs, which will have cost implications. We're exposing people to radiation. Some of these patients will be young or have cancer risks going on. We're making the queue for other conditions we need to diagnose worse. So there'll be delays for our head injury patients, our trauma patients, and anyone who's had to go through a day's worth of ED results will know about incidentalomas, where we find abnormal chest x-rays requiring repeating, bringing patients back and things. So, and this will just get worse if we CT everybody. In our practice, we're CTing about 5%. This is pretty much probably the UK national average. It's around about 4 to 5% of CTs of positive for aorta. I think if it's higher than that, we're probably not doing enough CTs. I'm just going to finish by talking about something called the ADDRS score, which is something that I said about 1 in 5 departments use in their guidelines. And this is one of the clinical decision tools to help us. The other one is the aorta score. And essentially, this is to decide who should get a CT once we've considered they might be the aortic dissection is something we need to think about. So there's 3 categories. We need to ask whether the patient has any predisposing conditions. Do they have any pain characteristics that are suggestive of it? And do they have any physical examination findings? So if they have any of the things in the first column, they score a point, but only 1 point. If they've got all 5, they still only get 1 point. They score any of the things in the second column, the middle column, they get a point. And if they have any of the things in the third column, they get a point as well. So they can either have a score of 0 when they've got none of those, or 3 if they've got something in all 3 columns. Now, can we use that to decide whether to do a CT or not? And obviously the gold standard is a CT aortic angiogram, which makes the diagnosis if we do it. Well, in this meta-analysis, the score itself, anyone who's got a score of 1 or more, so 1, 2, or 3, we CT scan, but we don't scan someone with a score of 0. We'll miss 1 in 17 patients with aortic dissection. That's clearly not acceptable. What if we scan everyone with a score of 2 or 3? We'll miss half of them. So again, this score in itself isn't useful. What about D-dimer? There's a lot of interest in using D-dimer now to rule out aortic dissection. Can we do it? Well, if we just use D-dimer on its own, nothing else, a raised D-dimer, and that might be 250 or 500, depending what your lab cutoff is for PE. So same cutoff for your that you use for PE in your hospital. If we just use D-dimer alone, so if you've got a normal D-dimer, you don't CT, and we see if they get a raised D-dimer, we CT them. We'll miss 1 in 25. So it's starting to get a bit better. What about if we combine the two? What if we say D-dimer and ADDRS? So if you've got a score of 1, 2, or 3, or a raised D-dimer, we're starting to get a little bit better here. So the sensitivity is excellent. So we won't miss many cases. We only miss 1 in 500, but there's an awful specificity, which means we'll still be scanning a huge number of patients with all the relative risks of future cancer and things. What if we say you've got a score of 2 or 3, or you have a raised D-dimer? This is getting a bit more like it. So we'll miss 1 in 167 patients that come to us for aortic dissection, which is pretty good compared to all other conditions. We accept 2% miss rate in acute MI and subaortic hemorrhage. And the specificity, this is about how many patients we're scanning, is actually much better. So there's certainly some suggestion that using a ADDRS plus D-dimer may be a safe option. However, hasn't been looked at in the UK, and a lot of these studies were done in acute settings, which were, say, cardiothoracic centres, or where you take everybody with chest pain units, so not all comers like we have in the UK EDs. So I've said there are a few other clinical decision rules. All the same, they lead to high rates of CT and have a lower diagnostic yield. We're leading a study at the moment, the DASH study, which some of you may have been involved with, which has taken data over the last few months from 27 hospitals, recruiting almost 6,000 patients to see if we can collect some data on how clinicians manage patients with aortic dissection. So hopefully over the next few years, we'll be able to develop this into a strategy to manage patients in the ED. So to finish, a few take-home messages. So first of all, aortic dissection is rare, but it's not rare enough that we won't see it. And we'll probably, if we're working in the ED, probably see a case a year. It is devastating, and it is often misdiagnosed and missed. But if we detect it in the ED, patients have 4 or 5 of our patients will survive and go home. The clinical features are very unreliable. It presents with chest pain, abdominal, back pain, stroke symptoms, signs of ischemia. But the key things to take away home are that a sudden onset of severe pain is aortic dissection till proven otherwise. It's a dynamic process. So someone presents with stroke-like symptoms and chest pain, or ECG changes with limb weakness. Again, that's pathognomonic for aortic dissection. They need a CT, and symptoms may come and go. So a patient may be well now, but may have been very unwell when the pain came on, but now may be fine. The pain might have settled, and they may be hemodynamically normal. We need to improve education. So we need to be better at thinking who we should consider in. And we also need a better detection strategy. So once we've considered it, what do we do? Because at the moment we consider it in far too many patients, and we have to decide ourselves who we should scan and who not, depending on our gestalt really, and things like something like decision rule or biochemical markers might be able to help us with this process. So that's it from me. Thank you very much for listening, and I think I've got a bit of time to take some questions.
Matthew, perfectly timed indeed. Thank you so much. I'm going to let you have a drink and have a look at the Q&A box and decide which questions we're going to be able to answer. I've just put a quick thank you in the chat to Holly, Duarte, Claire for leaving tonight's feedback. I have just popped some links in the chat. Let me just pop them in again to make sure that they stay there currently. Oh gosh, I do this all the time. I copy and paste it, and then I type something to somebody on Twitter, and then it just puts a random message. So I will put the link for Professor Matthew in the chat now, because equally, as well as your CPD tonight, Professor Matt can use your feedback for his own CPD. It's almost like a CPD roller coaster, isn't it? CPD for me, CPD for you, CPD for all of us. So please do leave us some genuine feedback. The links are in there. You will get the links tomorrow as well. I do think that they come by email. So if you don't get a chance to get them tonight, they will come tomorrow. But please do leave us some genuine feedback. More importantly, talking the feedback around how the information from Professor Matt might influence or change your practice, because then we know that the CPD circle is complete. Equally, I've put some links in the chat, so make sure you please do leave us some reviews. I already have seen some reviews come through, but I'm not very good at multitasking this time of night, so but we will acknowledge them. And again, you will be in the chance to win two £25 vouchers tomorrow to spend on Amazon, so you can buy yourself maybe a book on clinical examination skills, clinical history taking, or something that floats your boat. And of course, we have got some webinars coming up, so please jump over to our website at cpdme.com/webinars, where we've got a webinar tomorrow night on applying for a new job, and then psychiatric medication, and then one later next week by Professor Simon Carley on paediatric trauma assessment. And I'm pretty confident that that webinar is booked up almost, so please don't delay in jumping over there. Then, of course, if you ever do miss our webinars, or you're 10 minutes late or 20 minutes late, by virtue and nature of our audience, we know that you're often running home from work late. So a top tip for you is all of our webinars are live streamed for 24 hours after the live broadcast starts, and they always start at 8 o'clock. But if you're ever half an hour late and you think, oh gosh, I've missed that webinar, I wanted to catch up on it, if you jump onto the YouTube channel, you can actually watch it back live from the beginning, but then it's only on there for 24 hours. So that's a really good tip for you. The other good tip is we get around about 100 support tickets every single day asking where the links are. If you register for a webinar and you don't get the registration link within 10 minutes, it's likely your email has blocked it. So contact the support team. If you've got the app, you can even send them a WhatsApp message now. It's like really posh, this magic technology of how it all works. Okay, so let's go for some questions and answers. Let me see if I can get my mouse over onto the right screen, and we'll get to the question and answer box. So are you good for some questions and answers, Professor Matt?
Yeah, go for it. I see there's quite a few there. I think most I can tackle fairly quickly. So yeah, fire away.
Right, let me just clicked on the box and it's just close it down. Oh gosh, why can't I see my mouse?
I've got them here. Shall I start?
You can do, yeah. Well, I find my mouse because I can't find it.
So a question from Zoe here asking about how much of a bilateral blood pressure difference in millimeters of mercury would you make you consider a dissection? So I suppose I have touched a little bit of this in to say that I don't think it's, if it's present, it's a good thing to suggest a dissection. If it's not, it doesn't rule it out. So you're right that yes, if you see it, it might help you. I would say at least 20 would be my cutoff, but it's not a firm thing. You know, someone's got a difference of 60 or 70. It's clearly a blood pressure differential. There's no doubt about it. But whether if you do it once, it's 15, you repeat it, it's 30, you repeat it, it's 3. It's so variable. It's got to be a reasonably large difference and persistent as well.
Thanks, Zoe. Good question. Susie has asked, are there any lifestyle factors to consider in the older patient group that may heighten suspicion of AD?
So in a word, no, really. I mean, atherosclerosis does predispose to it. So things that predispose to atherosclerosis, so smoking, high blood pressure, an example. But other than that, it's all of the things that precipitate acute atherosclerosis. But as I've said, you can get it in patients with connective tissue disease. So I wouldn't let that sway you.
Fab, good question. We've also got another question here. When you say abrupt chest pain onset, is this over seconds or minutes?
So over seconds. So building up quickly over the course of seconds to a minute or so, similar to subarachnoid hemorrhage, sudden onset.
Excellent. And are there any considerations for administration of medication in the pre-hospital environment if we suspect AAS?
So if you suspect it, you need to get the patient to hospital. And I think covering another question there, that should be an emergency department, not a specialist unit, because people may be able to be transferred. If you have a choice to send them to patient to somewhere where there is acute hyalothoracic unit, that might be the better option. But normally you want to go to your nearest ED because there are lots of other possibilities that the presentation could be. But no, pre-hospitally, there isn't really anything. Pain relief, keep the patient comfortable, and get them to hospital.
Excellent. Question from Adam. Aside from the ADDRs, oh, that's just disappeared. Is there anything pre-hospital providers can do to improve identification or interventions for these patients?
So again, it's all on the history. So sudden onset, severe chest pain, consider it. And very importantly, once you've considered it, pass over and hand over that consideration to the emergency department team, because they may not think of it. And you may be the only person who's thought of it, and you making sure that information is relayed, that it's one of the differentials you're concerned about, may be the thing that leads the hospital staff to consider it.
Another question, what's your thoughts on TXA?
No evidence, and I'm not aware of any trials. It's a no for any aortic disease.
Question from Richard, would permissive hypotension be a good idea in the pre-hospital environment?
So no, lowering of blood pressure may cause worse perfusion to end organs that are not being perfused properly. So yeah, again, analgesia, hospital.
Excellent. Good tip for you. The analgesia and hospital pretty much sums up. Dr. Matt, thank you so much indeed for tonight. What a fab, look at that, perfectly timed, within 1 minute. That is just like, boom, easy. Remember, everybody, we will share the recording tomorrow. You'll also, if you are a member of CPDME, get your certificates. So once Fabio and Amy get in the office in the morning, once they're fueled up with some coffee, they'll get your certificates out for you. Please, I will stay online for another 5 minutes to answer any questions in the chat. So if you have any questions, you're more than welcome to either put in the Q&A or the chat, and I will stay live online. But on behalf of myself and all the team, Professor Matt, thank you so much for joining us tonight.
Thank you so much for the invitation. Lovely to meet you all.
Take care. Thanks, Dr. Matt. As I said, thank you all of you for joining me tonight. If you are at home, then kick off your slippers. Enjoy the rest of your evening. I will stay online to answer Q&As for the next 5 minutes. But if you have got any questions, either message the team tonight or message them tomorrow, either via WhatsApp or via the website, and they will be all over it first thing in the morning. But on behalf of myself and all the team, thank you so much for your ongoing and continuing support. And take care and have an amazing evening. Thank you.